Jacques with eye care. And from professional experience, I know he is exceptional and working with brain injury patients. Please welcome Jacques.
Thank you. And what a privilege to be here to talk about a subject that I'm extremely passionate about. And I just feel very honored and privileged to be able to share the information that we'll be going over today. So the talk is all about vision rehabilitation, but you can't talk about vision rehabilitation without talking about a little bit of eye disease and how strokes play into this and how we can actually do something about some of these problems. So the goal today is not to turn everybody into an optometrist by the time we leave, but hopefully give you a bit of an appreciation about how the eye is part of the overall body and it has its own intricate set of diseases and problems that we have to consider whenever we're talking about a rehab program for a patient. So this is a little bit about me. As Dana was saying, I have credentials at two different rehab hospital systems, Mercy and SSM. Every Wednesday morning, I go out to see patients and patient status, and we bring our gear out and staff and try to get intervention early. We find that really makes a big difference for the patients and especially the therapists. It's really a multidisciplinary approach when we're talking about neurovision rehabilitation, and everybody's got their piece of it. So some background on your TBI and CVA vision problems. 70% of all of our sensory inputs coming through the eyes. It's the way that we navigate the world, and you really don't know what you've got till it's gone, as the famous saying goes. 80% of learning is going to come through the eyes, and 90% of TBIs are going to have some sort of vision problem. It may be small, it may be big enough to be debilitating and affect activities of daily living. So these are going to be vergence problems, which are problems with the eyes moving together as a team, and we'll go over that in more detail. That's convergence when you're reading, looking at something up close, eyes moving in. Divergence when you're looking at something in the distance, like driving or watching television. And then that can be accommodative problems too, which is essentially problems focusing. 86.7% of CVAs are going to have some kind of strabismus or misalignment from either a cranial nerve palsy or an eye misalignment. And we'll go into those in more detail and what we can actually do about those types of problems too. So this is a very famous slide and concept in my background. 2020 isn't everything. You know, some people say, well, I've got 20/20 vision. That's great. Well, that's just a line on a chart. And it doesn't measure anything about somebody's functional ability to perform in the world. As you can see of the picture, if somebody's seeing double, they may still be able to make out the 20/20 line, but not very well, not in a way that's functional for them. If they've got problems like astigmatism or problems focusing, the letters can be blurry or skewed, but they can still read them if they had to. And if their eyes are moving in ways that they shouldn't be, they could still make out each letter individually, but it's not something that's going to be functional for them. So we like to differentiate between, some of these things that are measurements that may give us an idea of how well someone's seeing, but also taking into account what's the story behind that finding and how is that affecting their life. Snellen acuity is a very complex term because of how it's measured. And suffice it to say that at a distance of 20 feet, we measure something called optical infinity. And what that means is that anything beyond 20 feet, essentially your accommodative or your focusing system is completely relaxed, and it's the same as anything beyond 20 feet. So if you ever wondered what that term really meant, it's that kind of general concept that at 20 feet, our focusing system is completely uninteracted. And the second number has to do with the size of the letter. And so we have all of this mathematics that tells us how it's going to subtend cells of the retina, et cetera, et cetera. But just know that when we measure the acuity, it has to be at a very specific distance with a very specific size letter. And we can calibrate that for almost any environment. So I always joke that one day I'm going to walk into the rehab hospital and I'm going to be doing exams in the janitor's closet because they're just going to always looking for space. And ultimately, we can do these exams anywhere because we can calibrate our charts so that we know 20/20 in my office is the same 20/20 as it is in the field. So we'll be talking about confounding variables, is what I like to call them. These are considerations of ocular disease that basically every patient's going to have one or more of. And they're general concepts that I think, once explained simply, not only help you understand your visual system for yourself if you're having some of these problems, but also for your patients when they're expressing symptoms to you that maybe don't make sense. Blurry vision and visual field loss can be one of hundreds of problems, and we're going to touch on some of the more common ones and what to look out for. Knowing the general understanding of different refractive errors or problems with glasses versus eye diseases that may mimic the problems of a stroke or exacerbate the symptoms that a patient's having can go a long way in their daily function. So we'll start with one of the unfortunately most common ones, and that's diabetic retinopathy, which is the leading cause of new blindness in ages 20 to 74. It's also the most preventable kind of blindness that we have in the United States. And the problem is that so many patients that are diabetic have blood sugars that cause problems in the retina that can lead to irreversible vision loss or sometimes reversible vision loss. Each one of these slides of these major conceptive eye diseases will have an image that appears how the patient's perception is of the world. And so we call this sometimes Swiss cheese vision. Depending on where bleeding happens within the eye or swelling happens within the eye, it can cause central scotomas or even peripheral areas where the patient can't see anymore. And so sometimes a patient all of a sudden has a vision change because of a stroke, and turns out part of the reason they can't see is also because they have uncontrolled diabetic retinopathy that was either addressed and unable to recover vision from, or has never been found. So your risk of diabetic retinopathy goes up after 10 years of the initial diagnosis. And that's important because sometimes it's actually more important to know how long the patient's been diabetic for than to even know what their last blood sugar reading was. And mild cases are often found during routine eye exams, and that's because we can see very small micro dot plot hemorrhages in a normal retinal exam before a patient's symptomatic for it. And certainly if we find them early, we can write a letter to their primary care provider and say, this is a finding that could lead to irreversible blindness. Their HbA1c or their blood sugar glucose numbers may be under control or relatively good for them, but we may be wanting to do more so that we can keep them from losing their vision. So often begins with no symptoms, but it can affect the central and peripheral vision systems, as opposed to other diseases that may be only impacting the central or the peripheral vision problems. And the blurry vision can fluctuate from day to day because of the swelling of the intraocular lens. I had a patient just the other day who called and said she was very concerned because her vision seemed like it suddenly got blurry. My staff's trained to recognize that symptom and know we got to get them seen right away. She comes in, the retina looks clean as a whistle, but she had a refractive error change suddenly because the sugars had been so high that they caused her intraocular lens to swell, causing not only a glasses prescription shift, but also general blurry vision. Luckily, those types of problems are relatively transient, and she was going on a vacation to Jamaica, came back, and her vision was much better already. She said she ate a lot of fish during her vacation. This is kind of a scary picture. You'll see the photo on the left is of uncontrolled proliferative diabetic retinopathy, and the picture on the right is of a normal retina. And it doesn't take an eye specialist to know that one of those doesn't look normal. Anatomically, what we're looking at is the area through the pupil. The eye's round like a ping pong ball, and it's hollow, filled with a jelly called vitreous, and the retina lines the back. When the sugars get too high, the blood vessels can't withstand the blood flow anymore. Add hypertension or other confounding factors to that, and all of a sudden, the blood sprays out of the blood vessels like a garden hose with a hole in it. And the unfortunate thing is, there's a blood retinal barrier that shouldn't be crossed. And when it is, those cells can die and be damaged irreversibly. This is another picture of a patient I saw in my clinic with what I'd call mild to moderate diabetic retinopathy. And you can actually see there's areas, this is an unfortunate angle, right along here. If you can appreciate that large hemorrhage that's inferior there, we call that a boat hemorrhage. This is a patient that has diabetic retinopathy, but has been treated for it. And these black dots around the peripheral retina are called panretinal photocoagulation. And the reason that a surgeon would go in and treat this like this is because they're trying to preserve central macular and retinal areas from being impacted from the blood vessels that are either growing irregularly or bleeding. So if it can stop certain parts of the retina from needing the same nutrition, it can essentially stop some of the blood vessels from growing like they shouldn't. It's kind of like pruning a tree that's got a dead branch. You cut it off so that it doesn't have to spend resources on something that won't grow back. So when we're talking about our diabetic retinopathy, the considerations are always their last fasting blood glucose, their HbA1c, any glasses that they're wearing in their years since diagnosis. And it's important to know that because the problem is so widespread, and if a patient has a history of diabetes, they don't know their numbers, they've been relatively uncompliant, chances are they've got some sort of finding of diabetic retinopathy. And then we'll talk about cataracts, or more commonly known among some of my patients as Cadillacs, as they call them. And this is something that I like to describe to people as a problem that everyone will get eventually, as long as they live long enough. It's similar to wisdom teeth in that the cloudiness of the crystalline lens will happen. The question is, do we have to do something about it, and when? Most people have their wisdom teeth removed around a certain age, but not everybody. Same thing with cataracts. There's folks who they see well, even though the lens is starting to cloud. Maybe their pupil's extremely small or it doesn't impact their daily life. So they'll just keep on carrying on. But the average age for surgery is about 73. And I like to tell my 74-year-old patients that when they're kind of on the fence about it. But usually this is a problem that tends to progress with time and get worse, but not better. So here's our picture of what it's like to have a cataract. Problem with cataracts is they're such a slow progressing disease that you often don't even know you have it until it's really affecting your vision, or affecting both eyes rather than just one. It's not uncommon for me to cover up somebody's eye and they can't see a darn thing out of one eye. They cover up the other one and it's crystal clear. They say, I never realized this, I wasn't seeing anything. We don't walk around with just one eye. But it's important to know if someone's had a stroke and all of a sudden they feel like they're not seeing out of one eye, they may be hyper aware of vision that was actually gone before they even got into the hospital. It increases with age, and diabetes makes these things grow faster. So does UV exposure and smoking, and there's lots of environmental risk factors. But though it's a disease state, it's a semi-elective surgery, meaning the patient has a say in what they're going to do about this, and so does the doctor. I, as a doctor, if I can't see into the retina because the crystalline lens is blocking my way, I'm going to advise my patient to have cataract surgery. Or if they're meeting certain criteria, like they're not seeing well on the eye chart, better 1 or 2 tests isn't getting them seeing any better, it's affecting their daily life, those sorts of things. For the patient's point of view, if they're having trouble with night blindness, headlights on the car seem like they're giving them a lot more glare than normal. That's one of the first symptoms. So is reading, difficulty reading. So symptoms are clouded, blurry, or dim vision, increasing difficulty with night vision. And there's oftentimes a change in the eyeglass prescription, but some of them we can ask better 1 or 2 all day. We'll never find a lens that'll correct their vision because the problem's inside the eye and not glasses. These are pictures of different stages of cataracts. We use what's called a slit lamp to observe the crystalline lens and grade it on a scale of 1 to 4. I joke with my patients, I say, 4 is like you should have had cataract surgery 5 years ago. A 1 is I might not even bring it up. So it may not be impacting you that much. I may say something about a cataract and they say, well, no, never said anything to me about that. I said, well, it's probably been there this whole time. We just didn't say anything because it wasn't doing anything for you. But I like to bring it up as soon as we see it so that we can at least have the conversation. Patients aware of the symptoms that cause them to need a referral. And then that way they can kind of be in charge of their own health. So I get the question about Coke bottle glasses, not as much now as I used to, because that used to be the only correction for cataracts. We used to take the lens out, pluck it out like a grape, and then we had nothing to put back in its place. So they had to use a really thick lens in front of the eye in order to make up for the 20 diopters or so of power that they removed. Not anymore. We have these super sophisticated slick intraocular lens implants that patients can have installed in their eye. We can almost mimic contact lens prescription or glasses prescription when we implant it. And some of them don't even need glasses anymore after cataract surgery. They say, why didn't I have this done years ago? But it's important to know about cataracts, not only because your patient the patient may not have ever had it, and it could be impacting their vision quite a bit, or they've had cataract surgery, but 1 or more complications have happened afterwards. It's not uncommon for patients to need glasses again after cataract surgery. They may be fine for 3 or 4 years, but at year 5, all of a sudden, the eyes still continue to change and grow, and they need glasses again, either for distance or up close or both. It's also important to know that there's a clouding that can happen of the intraocular lens capsule. We call that posterior chamber opacification, and it's taken care of through what's called a YAG post-capsulotomy, which is a super routine procedure that's done in the United States. But some people will say their cataract feels like it's growing back again, which is impossible because we took it out. But the fact that we left in its place can cause cloudiness. It's also good to know just generally how the surgery goes, because not every patient can say, I've had cataract surgery, or know that that's exactly what they had happened to them. But there's several follow-ups, a 1 day, a 1 week, and a 1 month per eye. Normally it's a total of 5 visits because one will be overlapped because the eyes will be done about 2 weeks apart. They'll take lots and lots of eye drops for a period of about 1 to 2 months. And after that, they can usually see pretty well. They might need glasses afterwards. So I'll say, hey, have you had cataract surgery? And they'll say, oh, I don't know. I'm like, did you have surgery on your eyes at all? Yeah, I had LASIK 5 years ago. We're like, okay, did they put an implant in? Did you have to take a bunch of eye drops? Oh, yeah, I took a lot of eye drops. Did you have to go to that doctor 4 or 5 more times? Oh, yeah, I was back there every week, it felt like. Okay, yeah, you had cataract surgery, not LASIK. So this talks a little bit about the complications. Again, this can cause blurry vision, can be some confounding factors when it comes to patients who've had stroke. It just so happens that these diseases line up right with the same age that we're at risk factor for stroke, traumatic brain injury, all those sorts of things. And then we'll wrap up with just a couple more quick eye diseases and then get more into the meat and potatoes of stroke and traumatic brain injury vision problems. So macular degeneration is another super common condition, unfortunately, which is a slow degradation of the central vision. So to recap, we had diabetic retinopathy that can affect central, peripheral vision, pretty much everything. We've had cataracts, which is a slow progressive vision loss over time. That's usually a clouding of the crystalline lens. Now we've got macular degeneration, which is a slow progressive disease causing the central retina or macula to degenerate. The pathogenesis of the disease is essentially that the areas of the retina that are responsible for removing waste don't do so effectively anymore. The retinal pigment epithelium and the different areas of the retina start to become backed up, and this trash, so to speak, called drusen, starts to accumulate. And over time, if it gets bad enough, or through the progression of the disease and ultraviolet light exposure, can cause this central vision loss. It can also have a subtype called geographic atrophy that the dry type of macular degeneration is at risk for to have vision loss. Some people think the wet kind is bad and the dry kind is good. And in general, if you had to pick, yeah, you'd want the dry kind. The wet kind implies that there's new blood vessel growth, similar to diabetic retinopathy, causing a leakage of the retina, which is resulting in the irreversible vision loss. That's what the wet is. It's fluid and blood building up in the retina. But the dry kind can have vision loss too, and not everybody knows that. So some people say, I'm fine, I got the dry kind. I take a vitamin and I'm good, but not necessarily. So this is an example of dry macular degeneration in advanced geographic atrophy. This patient is probably legally blind, worse than 2400, best corrected, and it's mostly affecting their central vision. This type of patient may do something called eccentric fixation, which means they'll say, well, if I turn my head like this, I can see the big E, but if I do this and I look straight ahead, I can't see anything, doc. And what they're doing is they're using part of the retina that's unimpacted as badly from the condition in order to accomplish some sort of vision. And so they're literally turning their head and pointing the light into peripheral retinal areas that are less impacted by the disease. This is an example of what's called an Amsler grid. This is a self-home screening that these patients can do. What they do is they look at the central dot, cover up an eye, and they look for any areas of these boxes that are missing or irregular. And these distortions actually correlate really, really closely to the findings that we see in the clinic. So in particular, this is an example of wet macular degeneration. We've got the Amsler grid, areas where the patient actually drew what they saw. We've got something called an OCT, which showed the macular edema and the swelling of the from the fluid accumulation there. And then here's the actual retinal photo. So all three correlated really nicely with each other. The treatment in the early stages, in the intermediate to advanced stages, is AREDS2 supplements. So this is one of a handful of studies where the evidence is unbelievably unchallengeable in terms of supplements really helping. I mean, supplements are fantastic, and nutraceuticals is an industry that's unfortunately unregulated, but AREDS2 supplements are one of the best things that we can do to treat intermediate to advanced AMD. And then when things progress beyond the dry form and they go into wet AMD, we've got intraocular injections. And there's even new studies that have even recently come out as this year and last year that are showing we've got some promising treatments for geographic atrophy. So the last big disease we'll talk about is glaucoma. And you can think of this as almost the opposite of AMD. It's going to affect peripheral vision rather than central vision. And it's much more than just eye pressure, which is sort of the finding that people correlate with glaucoma. Like, oh, I got that puff of air test in the doctor and they were checking for the glaucoma. They're not entirely wrong, but we've got one piece of a big, big puzzle. And part of the problem is the more we learn about glaucoma, the less we can definitively say you have it. And it seems kind of counterintuitive, but the problem is there's so many risk factors, and we know that things go so much far beyond the eye pressure. Things like family history, we can see optic nerve irreversible damage just from low eye pressure, low tension glaucoma. Patients can have high eye pressure. We kind of use this bench line of 21. Things can be 26, 27, and they may never develop glaucoma. So we call it the silent thief of vision. It's hard to early detect. It's usually very slow in its progression. And there's so many risk factors and so many things we have to watch over time in order to come up with a diagnosis that it becomes really tricky to treat and manage sometimes. But when we do get it, we put the patient on an eye drop. It's usually one drop at nighttime, a prostaglandin analog. And so someone will say, I'll say, oh, do you have any eye history, macular degeneration, glaucoma, et cetera? Oh, I've got cataracts. Like, okay, yeah, a lot of people do. Have you had surgery? Oh, no, I take an eye drop for it. Okay, when do you take the eye drop? Every night at bedtime. Okay, you've got glaucoma, great. So it's not always, the terms, they're confusing and they get mixed up a lot. And the history goes a long way when it comes to kind of figuring out which one they're talking about, because it's important that if someone says that they've had a history of glaucoma, I'm going to think this may be impacting their peripheral vision. How much of this is glaucoma? How much of this is stroke? So here's a picture of an optic nerve. And what we're looking at is this little yellow circle right in the center of the retina. And over on your right-hand side, this is a normal optic nerve. It's hard to appreciate on the slide here because of the lighting, but there's a very small, what's called cup to disc ratio. The lighter area compared to the overall area surrounding it is very small. And we like to see that. That means you're at a low risk for glaucoma. On the left-hand side, this is what's called the cupped out nerve. There's peripapillary atrophy all around the edges. It's kind of that darkening area that you see around the border. And it's very hard to distinguish where the lighter area is compared to the surrounding disc as it is in this one. So this one is a more advanced stage of glaucoma. This patient probably has very little peripheral vision left. And this patient over here probably has perfect peripheral vision. So management, again, we do lots of visual field testing because we want to see, is this affecting your peripheral vision before you've even had a chance to realize it is? The treatment is fairly simple. We'll start with one drop at bedtime. And the goal of the eye drops is to lower the eye pressure, which is, again, probably where the correlation between eye pressure and glaucoma becomes more solidified. The problem is it's the only modifiable risk factor we've got. I can't change your age, I can't change your race, I can't change your family history, but I can change your eye pressure. And that's why we target that for the treatment. And all the treatments in one way or another are involved in either lowering the pressure by decreasing outflow of the aqueous humor, which is the fluid inside the eye, or decreasing production. There's also several surgeries that they can do for glaucoma. Talk about confusing. One of the major glaucoma surgeries that's done in the United States these days is actually done in correlation with cataract surgery. So have you had cataract surgery? Yes. Have you had glaucoma surgery? Yes. Were they the same day? Could be. All right. Quick overview of refractive error. Looks like lots of people are wearing glasses. Does anybody know if they're nearsighted? Has anybody been told they're nearsighted but doesn't know what that means? It's okay. It happens all the time. I say that our layman's terms for these conditions are horrible. The layman's term is supposed to define the term without the fancy one. But our myopia or nearsightedness means that you see well close up without the glasses. Now, the problem is after 40, you lose your ability to see up close and now you can't see anything. So you can be nearsighted, but also have the problem up close too. So we'll talk about the myopia first. So again, I like the simulation. I like to show you from the patient's point of view what they're going to be seeing. So, okay, I've had a stroke. I'm in the hospital. Now I can't see. What's the problem? Is it my stroke? Is the problem inside my brain? Is the problem that you actually have myopia and you can't see in the distance, or is it both? Oftentimes, it's both. You could have diabetic retinopathy and myopia, and you can't see from the stroke. So this is a condition where it primarily affects your distance vision. This is going to cause the line on the chart to be really blurry. You may be able to only see the big E without your glasses. But if you're young, under 40, and you look at something up close, it's going to be crystal clear. So how can you be 20/20 right here and 2400 out there? Well, it's because your eyeball is too long for itself. The light's focusing in an improper place. We need to push that focal point back with a lens that we put either in front or on your eye, and bada bing, bada boom, it clears everything up. Now, myopia more recently has become sort of we call it the epidemic of myopia, because we're finding that people's eyeballs are elongating faster and more than they should. And so there's been lots of pushes into what we call myopia control now, which is trying to stop these prescriptions from getting higher by stopping the eyeball from getting longer. And it's kind of the forefront of optometry right now, because all of these diseases can be increased with myopia. As your myopia goes up, your risk for disease goes up. So kind of the holy grail is, if we could stop the myopia, we might be able to stop the disease from ever happening. Seems simple that, but it's a win-win. You might not need glasses as bad, and you might not get any diseases later in life. So pretty cool. This is an example of a routine patient that showed up for a contact lens check. And out here in the peripheral retina, she had all of these, let's see, laser pointer gonna work. Hard to get it right at the right spot. Right along here, these are areas where there was retinal holes. Now, luckily for her, one, she was asymptomatic, it hadn't affected her vision yet, but two, we caught it early. And if you look right in the center where that yellow circle was when we talked about glaucoma, and the dark spot next to it when we talked about macular degeneration, those are the areas most responsible for vision. So the reason she was asymptomatic was because this problem was so far out in the peripheral retina that we wouldn't have seen it if we hadn't either taken a special photo or dilated her eyes. But those are the kinds of things that can happen with myopia. Hyperopia and presbyopia. So essentially the same type of blurriness, but for two different reasons. One, hyperopia happens because the eyeball itself is too short. And so therefore the light is going to be focusing behind the retina. We've got to put a special lens either on or in front of the eye to bring it back to where it's supposed to be. But after 40, the lens inside the eye, which is squishing every time you bring something arm's length or closer, starts to lose its ability to flex. And that we call presbyopia, or literally Latin for old eyes. And I love this picture because it shows one of the chief complaints that I'll see in the clinic, which is, my arms aren't long enough anymore, doc. I can't hold them any further. As you push your focusing system back further, it doesn't have to work as hard. So over time, as this problem progresses, you'll push something back further and further and further to change your working distance to make up for what the eye's focusing system can't do. And it's very common. It's so common that's going to eventually happen to everybody. And sometimes you need glasses for it, sometimes you don't, but most of the time you do. All right, now we finally got astigmatism, and then we'll switch our gears over into the vision rehab half of the lecture. So I call astigmatism no-sightedness because it's not nearsighted, it's not farsighted, everything's blurry. And the reason is because the shape of the cornea, or the front surface of the eye, the area that covers the front of the eye like a watch glass over a watch, is irregular in one meridian more than the other. Some people say, the doctor told me my eye's shaped like a football. Does that mean anything to you? Does that help you understand this? No, I just know I got football eyes. That's all I know. So the problem with our layman's terms is that it's not describing what's happening. It doesn't tell you what you're experiencing when you're uncorrected. This is going to cause a lot of glare, especially at nighttime. Sometimes these are the patients that just wear glasses when they're driving. At nighttime, when the pupil's bigger, more light's going and refracting on those parts of the cornea that are irregular, and it's causing lots of glare. These patients might be able to see 20/20 on the eye chart, even with large amounts of astigmatism. One of the reasons that this is really important is because double vision happens in stroke and traumatic brain injuries so commonly. But as you can see in the simulation of what it's like to have astigmatism, laser pointers. Problems on the bottom, the A looks like it's got shadows. So sometimes I'll say, if you cover up an eye, do you still see the double? Yeah, I see it. Does it look like there's a shadow of another A, or is there another whole A? And then there's like an A, and then there's like another A, but they're connected, and it's like kind of like a blurry A, but then a good A. Probably more astigmatism, honestly. And the double vision that happens from stroke is generally going to happen when both eyes are open together at the same time. It's pretty rare to have a unilateral diplopia. And when you do, it's either astigmatism or usually a problem in the macula, but it's never a good thing if it's not astigmatism. And then we'll talk a little bit about glasses. So glasses to fix this problem. Again, I'm not trying to make everybody optometrist, but these are two pictures that I love because they show you exactly what's happening in a lens that somebody might wear either after 40 or as a child with an accommodative disorder. So the one on the left is a progressive addition lens. It's got distance, intermediate, and near. It progresses between all three from top to bottom, and there's areas of peripheral distortion on the bottom left and the bottom right. Over on the right-hand side, you've got a traditional bifocal. You'll notice that the blue area on top is from the edge to the edge, and there's no cut in, so to speak. There's just a blue spot and a green spot. You've got distance from edge to edge. You've got clear near from edge to edge on that little green area of the lens. And there is a small image jump that happens when you look from distance to near, but for the most part, you've got edge-to-edge clarity. So this is an important concept. If a patient's got dizziness, or they've got mobility issues, or they're having trouble walking, or the world is double, if you add some peripheral distortion to the edges of their lens, it could exacerbate the symptoms. The type of glasses that they came into the hospital with may be causing part of the problem. Or the fact that they don't have glasses at all could be causing part of the problem if it's something like undiagnosed or uncorrected astigmatism. Okay, rounding the corners here to visual field defects. So we've talked about these confounding diseases, these confounding factors. The ones we have to keep in mind when we're talking about a visual field defect are usually going to be the diabetic retinopathy, the glaucoma, and the cataracts. And it could be a mix of all three, none of them, or, it could just primarily be one of those. Unilateral spatial neglect is also reported in about 25% of stroke patients referred for rehabilitation. And we'll talk about the differences between what we would consider clinically as a field cut and a neglect. Neglects are going to occur more commonly with right CVAs, and it generally is going to occur in the left hemisphere. And we'll talk about why that happens. But it's a defect primarily in the parietal lobe, but also can happen temporally or in the frontal cortex. And the left CVAs are usually more common than the RCVAs. So we'll talk about a pure field cut, kind of what we would expect if you were to look it up in the textbook. And then also consider that the fact, to make it even more confusing, that a field cut and a neglect can essentially happen at the same time. Some people in the field are starting to think of this like a spectrum. Rather than having a field cut or a neglect, maybe you're somewhere on a slider. And maybe it's more neglect than it is field cut, or maybe it's more field cut than it is neglect. But depending on which one's impacting them more, maybe depends on the type of therapy approach that we would take. So how do we find this problem? Well, we do a test called the confrontation visual field, which is very simple. It's got a long-winded explanation here, but essentially the patient covers an eye. We split their visual field into 4 pizza slices, and we hold fingers or some kind of stimulus in each one of them. And what we're looking for is there an upper left, a lower left, an upper right, a lower right, or a combination thereof that we're not seeing? When I was in school, I remember thinking, like, what's that going to tell you? We have these sophisticated ways to measure visual fields. It's just a couple fingers in the air really going to do it. And what we find in practice is that it's actually extremely reliable. And it's also useful in determining whether or not someone's stroke or traumatic brain injury problem is maybe more permanent, more transient, more treatable, less treatable, whether we need to go into a rehabilitation or more of an adaptation type of philosophy when we're treating the patient. So compare and contrast that to our types of neglect. So when we do our confrontation visual fields, we're looking for certain types of responses. Is the patient generally aware that your fingers are there, especially when you only have one stimulus? We know that things like unilateral spatial neglect tend to worsen when there's multiple stimuli in place. So something that we may do is what's called look for an extinction phenomenon. So we'll have the patient cover an eye. We'll have them say 1, 2, 2, 1. Okay, great. all four quadrants are fine. Now we'll introduce a second stimuli. And they'll say, two. Okay, well, we missed these two on the left. That's interesting. Let's cover the other eye, check it. Okay, same thing. Two. You holding any fingers down? So now we're seeing, okay, are they seeing over to the left on, one half? Are they seeing on both halves? Do they need one stimuli? Do they accept two? And in general, and there's no real laws here, but in a unilateral spatial neglect, we'll see them have a positive extinction phenomenon. They will be gone, the visual field will be disturbed when two stimuli are present, but not when just the one is. So that's one of the easiest ways to say, okay, this is looking more neglect, less field cut. So we talked about how it happens more on one type of lesion than the other. And so if you look at this picture all the way to the left, you'll see that there's a little bit of discrepancy when it comes to visual attention. The right part of the brain is actually responsible for attention on both the left and the right visual fields. The left side of the brain, however, is only looking at the right visual field. So when we have a lesion on the right hemisphere, the reason we will see left-sided neglect very commonly is because you have wiped out that overlap in attention. So all we're left with is the left hemisphere's attention over to the right visual field, and we have our left hemispatial neglect. Compare and contrast that to a left hemisphere lesion. Why don't we have any neglect? Why does it seem like right neglect is just more rare? Well, it's because when you've got that left hemisphere lesion, you still have the overlap from the right visual fields to be able to attend to both the left and right visual hemispheres. So on that note, when we see the left hemisphere lesions and we see the right neglect, it's usually pretty debilitating. It maybe is like multiple hemorrhages or a large brain tumor or something that's overlapping hemispheres. It's usually pretty severe, and there's a lot of times other things that are going on, the types of dysfunctions that we'll continue to talk about throughout the lecture. So usually it's not just in isolation. If we have a patient who's relatively high level, they just don't really remember or realize that they've got a left side anymore, it's like slam dunk. Your vision rehabilitation is going to go so well. We might even cure you before you leave the hospital, and that's the goal. But at the very least, we can set down some foundations, start to do some rehabilitation that might help you, before you even leave. And then we can pick up the paces once we're out. Now, part of the reason this gets very confusing very quickly is because most nurses, occupational therapists, optometrists, medical doctors are exposed to this type of map while in school. And for some people, this is causing PTSD, so I apologize, but hopefully I can simplify it for you. We split up these visual field defects either pre or post chiasmal, meaning the areas where everything is crossing right at B, we're talking about things that are in front of it or behind it. Now, the A lesion is lights out on both sides for one eye. That's because you're essentially clipping the optic nerve. That's relatively rare. The areas where the optic nerve passes through are fairly well protected. And even in like a stroke from the prefrontal cortex, we won't generally see severe vision loss in one eye. It's usually something more like a problem or a disease state that was within the eye, like glaucoma, macular degeneration. Those would be the problems that would cause one eye not to see. Post-chiasmal, C, D, E, and F, those ones are the ones that tend to cause the peripheral field defects that we're seeing in strokes. And the reason for that is if you think about where C is in the brain, you think about the circle of Willis, you think about these areas where the arteries all come together and cross and branch and start to feed different parts of the brain. That's the most common area for a stroke to happen, is the parietal lobe lesions that happen from a RCVA or LCVA. And these are going to give your super clean left and right visual field cuts. And they're happening because those pathways, those blue lines in C, are where the information is going from, literally like a wire from a computer into the occipital lobe for processing. And so when we have lesions there, the reason the vision loss is generally irreversible is because those optic nerve areas post-chiasmally are becoming disrupted irreversibly. The nerves are becoming severely damaged and they tend not to grow back. Now, we may take these patients into account and consider this as more of a adaptation type of therapeutic approach rather than a rehabilitation approach. We may start to think, how can we help you overcome this challenge that may not be getting any better? And they tend to be fairly clean when we do visual field testing. And I'll show you some examples of those visual fields that we do. Now, it's also important to know, and experienced therapists and nurses start to find this, is that sometimes it's not just half the field, sometimes it's a quadrant. And the further back you go, the more posterior the lesion, with the exception of straight occipital lobe lesions as an F, we're looking at D and E here, this is generally going to cause one quadrant of the vision to be impaired. And that's because between C and E, there's an area called the LGN. It's a nucleus where all of these tracts come together and branch off into these optic radiations. And because of that split, literally fanning of the neurons, if you cut half of them, you may only have one quadrant of the visual field impaired, either upper or lower, depending on how inner or outer the lesion is. So hopefully that adds a little bit of context to this map that we've all had to memorize at one point usually, but then forgot. So again, here's anatomically what we're looking at. And to compare and contrast this from neglect to visual field cut, we're talking about parietal lobe lesions responsible for visual attention versus intracranial hemorrhages that may irreversibly damage the optic nerve tracts that are responsible for carrying the signals of the visual field. Now, this is a very common test that's done called a clock drawing test. And when a patient's only seeing half of their world, what is this really telling us? Is this telling us that they're just not attending to one side or the other? Is this something that we can quote unquote cure or restore? Or is this something that's irreversibly damaged? And in general, there's some rules of thumb that we carry. One is, if the patient is cognitively aware enough to observe for themselves that they can't see to the left, not because someone is telling them they can't, it may be more of a cut. If they're reporting that other people are telling them that they're not seeing them when they sit over to their left-hand side, it may be more of a neglect type of problem. And so there aren't hard and fast rules, and because it feels more like a spectrum and the same parts of the brain essentially are impacted, though the specifics get more nuanced, part of the philosophy is, well, why don't we treat it and see what the outcome is, regardless of what really caused it? What if we were to treat this like a neglect, even if it didn't come back? Have we done any harm, or did we actually have some good prognosis for the patient where we can actually see some improvement? This is a simulated experience of a patient who's got a true left-sided field cut. They literally, half the world is just gone. You can move their finger from their right side to their left side, and at a certain point they'll say, no, it's gone. I can't see anything. Oh, there it is. Yeah, I got you. No, it's gone, doc. I don't see it. Nope, I got it. So those sorts of things are fairly common in a very severe cut. So what are we going to do about it? What's our intervention technique for this? Well, neurologic neglect syndrome luckily has been studied to death. Part of the problem with the studies is they don't nuance between the field cuts and the neurologic neglect syndromes. There's different scales and assessments that we can do that will suggest severity of neglect. However, there's overlap in these symptoms between neglect and visual field cut. So we're going to treat it more or less like a field or a neurologic neglect syndrome. We're going to hope that the outcome is good. And we're going to use 20 diopter yoked prism goggles, which are one of my favorite tools in my toolbox for these types of problems. And most of the great research that was done by therapists through the Kessler Foundation. We call this the KF-NAP and the KF-PAT. One is the neglect assessment process, and the other one is the prism adaptation treatment. So one is actually testing for the problem, the other one is treating it. So we have these fancy goggles. We're going to record a baseline before the prisms are applied. And what the prisms are essentially doing is shifting images in the world. Now, we're going to talk a lot about prisms because it happens to be the same way that we're going to treat diplopia or double vision. And in this particular case, because they're yoked, because they're both in the same orientation, they're shifting images in both eyes in the same direction, essentially in the same amount. So our quantity here is 20 prism diopters. This is essentially at 1 meter, moving of one prism diopter at 1 meter displaces 1 centimeter. So this is about a 20 centimeter shift at 1 meter. You imagine everything that you're looking at straight ahead, but just being over there now. And as we reprogram the brain, doing some kind of proprioceptive feedback or some therapy that's involving the eyes, the brain, the coordination, tactile response, physical feeling and reinforcement, we can reestablish in the brain a connection that stimulates the neglected side. So the way I kind of explain it is, if we were to move, if you couldn't see to your left, well, you weren't aware that you couldn't see to your left, and we gave you base left prisms, it's going to shift everything to the right, counterintuitively. You think you'd want to shift it over to the side where they can see. But instead, we're going to shove it over into the side where they can see. We're going to displace both visual fields into the visual areas that are being attended to. So all of a sudden, temporarily, that patient is experiencing full vision again. Their right-hand side, which is unimpaired, now has both a left and right side again. We've shifted it all over into the side that's working fine. So we reprogram the brain. Now it's all of a sudden remembering, oh yeah, I got a right, I got a left, and no big deal. I was fine before though, but we're just going to do this exercise as the therapist told me to. And then they remove the goggles and there's an overcorrection over into the neglected side. It almost works like magic. And the beauty of it is we can actually measure on a scale exactly how far over they're shifted and how far their neglect is. And afterwards, we can watch the return to baseline. And things like their activities of daily living become way improved. Beforehand, a patient might eat half their plate of food. They might shave half their face. They may neglect the fact that they've got their coffee over to the left and, yell at you because you didn't give them their coffee. And afterwards, it's like it never happened. And 1 or 2 or 3 treatments even, we see huge improvements. But what the research also suggests is that after 8 or 9 or 10 sessions of this, there is a compounding result where we actually see accelerated improvement even after the therapy is discontinued. You could take a patient who's gone through those 8 sessions, 5-10 minutes a day, and then after that, measure them 3 months later, and you can continue to see the improvement versus someone who didn't have the treatment. So here's some examples of some assessments that maybe an occupational therapist might do in the clinic. We love the one called the star cancellation. Essentially, a patient's asked to find all the small stars, circle them, and depending on how many stars they got, it's kind of a measurement of their neglect. And then same thing, asked to copy a drawing. They may neglect half of the drawing. A very simple test that we can do. And we can also measure this in the clinic with our visual field testing. Each one of these is a map of someone's peripheral field that we're able to establish in a clinic. And essentially, the patient is presented with white stimuli, either bright or dim, asked to acknowledge when they see it through a clicker. And then this maps out how they're seeing. And over time, we can remeasure and we can actually see these visual fields improve. So if you look over on the right-hand side, versus the left-hand side, we've got both the left and the right eyes represented here. And as we continue to test versus baseline, especially on that superior left visual field, you can see those areas that were black or dark gray start to recede. And all of a sudden, those darker areas where they weren't able to see get improved. So it's pretty cool that we can measure it that way. Again, here's a patient who at the baseline test, we were showing a very significant left visual field cut. And after about 3 or 4 weeks of therapy, the inferior left visual field began to come back again. This was, about 3 weeks between these 2 tests. And all we did was 20 diopter prism adaptation therapy. Okay, so I'm let's see, we're 40 minutes. I don't have time for questions, so I'll speed through some of the diplopia work, kind of hit the highlights. Okay, so we've still got our confounding diseases, astigmatism, like we talked about. Cataracts can cause sometimes diplopia, and diabetic retinopathy. So I like to say that there's 12 cranial nerves, and we get 4 of them directly in the clinic. Cranial nerve 2, which is the optic nerve, which takes the information from your eye back to your brain. And then 3, 4, and 6 that are responsible for eye muscle movements, with 4 and 6 only being responsible for one muscle. That's how complicated the extraocular muscle system is. It takes 3 cranial nerves just to make it work. So you can imagine if 1 or more of those was disrupted, you're going to have lots of problems. And the problems tend to come in diplopic symptoms or double vision. That's the most common thing that we see. And so This problem of double vision can happen from a lesion anywhere along these pathways. It can happen from an origination of the nuclei, where the cranial nerves are actually originating from, or anywhere along the pathway as it makes its way from the brain stem, the pons and medulla, up to the eyes. And the symptoms can be very obvious or they can be subtle. So these are 3 examples of cranial nerve palsies. These are areas where one cranial nerve was impacted. On the very top, we have what we call a characteristic down and out. This is a cranial nerve 3 palsy. And if you look closely, you'll see a few things. One is the eye is down and out, again, like the name suggests, but there's also going to be a ptosis because cranial nerve 3 is involved in the eyelid. And usually there's a pupillary defect as well because it's innervating the pupil. We may sometimes see a head tilt in a trochlear nerve palsy, and that happens because the trochlear nerve is responsible for cyclorotation. And so sometimes the head will start to do what the eye can't. And by that, I mean, if it can't keep itself straight, they'll start to drift. And sometimes they'll just walk around like this. Now, sometimes it's because of the stroke and there's other physiological things happening. But sometimes when we ask them to straighten out and do this, we'll say, do you have double vision now? They'll say, oh yeah, it's real bad. It's like up and down and to the side. And then they'll slowly drift this way and be like, oh, it's gone. Oh no, I'm fine. So those are some of the things that we see. And then the abducens nerve palsy is relatively rare. It usually has to take a lot of trauma in order to get one of those. Sometimes, though, the abducens nerve will be impacted in what we call internuclear ophthalmoplegia, which is where there's a disruption between 2 of the cranial nerves as they connect to each other. So in other words, because the eyes have to move in such a delicate dance together in order to move just left and right, they have to have connections to each other. So as one moves, the other one follows. When there's a disruption between those connections, sometimes we'll see super obvious problems as patients try to look left or right. Maybe they'll have one eye that stops halfway through its journey to the left, and then the left eye will keep going, but it'll have a nystagmus because it's like, hey, the right eye, come on, like you're supposed to come with me here, and we're on a journey together. And because they're disrupted, that yoked response gets impaired. So what are we going to do about it? What can we do about diplopia? Well, luckily, it's super treatable through a combination of therapeutic intervention and prism therapy. And one of the easiest ways to treat it is to help the eyes realign themselves, point themselves together as a team, and hopefully use parts of the brain and neuroplasticity to overcome the problems because of some of the nerve damage that may be somewhat irreversible. And sometimes we'll need some of these interventions long-term. Other times they'll be transient and they'll resolve. Sometimes some of the worst problems I see are gone in a month. It's amazing what the eyes and the brain can do when they start working together again. So the goal is always to start with both eyes getting some kind of input. What we don't want to do is eliminate one of the eyes or the images in one of the eyes, because all of a sudden we've broken binocularity, and that's not the way the visual system was designed to work. So if we can't see with both eyes together, we're usually not going to be able to help solve the problem. So that means that eye patches can sometimes do more harm than good. So instead of an eye patch, we're going to do partial occlusion if even needed. Maybe we'll just put some tape on the lens to help the eye from having to work quite as hard to get itself over. Maybe we'll give it a back door. I'll let it, kind of relax a little bit so that you're not seeing double, but then every now and then it'll squeeze itself back out again as you start to do some therapies, exercises, or just continue to do your daily living. But what I like to try to do, if it's a problem that warrants it, is use a special prism. And we can apply either temporarily or permanently a prism to a lens that can sometimes help the eye sit more naturally. And the reason we do it is because we're trying to get fusion. We're trying to get the 2 images to align to each other, first and foremost, so that we can start letting the eyes do the rest of the work. And sometimes these exercises are very simple. This is a picture of a Brock string, and I might apply a prism to a lens so that we can accomplish some in-office therapy where the eyes are supposed to point themselves together at the same target. It seems simple, and it is, but it's very powerful and effective when done correctly. I use the analogy of a baseball player playing catch. They're going to play catch, it's easy, but what they're doing is building hand-eye coordination. If you can build eye-brain coordination just by doing simple exercises like that, then the effects can be very powerful. So we'll have the patients look at these different beads on the string. Sometimes we'll bring one of those beads closer. help them converge their eyes together as a team. And as soon as they hit a breaking point, we try to work through those areas so that we can continue to build improvement, get things closer more naturally. And the beauty of the string is that it gives you feedback in your brain. So if you were to imagine yourself as a child again, learning how to wink or raise an eyebrow, you had to sit in front of a mirror because you had the ability to manipulate your skeletal muscle. You can move it on your own. You have full control over it, but you don't know what to do. You can't tell someone, here's how you raise your eyebrow. You could demonstrate it. You could show it to them. But what they really need to do is see themselves doing it. And as they watch, they're building biofeedback. And all of a sudden, the ability to move those muscles in the way that they want is accomplished because they can see it happening in front of them. And that's what the Brock string does. It helps you see those things in front of you, bring them together, and helps you know, am I seeing with one eye or two? Talked a little bit about Prism, how it displaces images. This is what it looks like if you're going to look through a prism and you don't have a problem. It's going to move things. Well, that doesn't help you very much if you have normal vision. But imagine your eye is sitting a little bit too high up. Well, what if I raised the image to where the eye was? All of a sudden, we can obtain fusion. Then we can start working on moving the eyes more naturally together as a team. And then we'll wrap with pursuits and tracking. So saccades and pursuits are different terms that we use for either looking at stationary objects or moving objects. Saccades are responsible for stationary objects, responsible for things like reading. And pursuits are going to be things that are in motion. And we're going to use that system to watch things like a ball flying through the air. Something that really blew my mind in optometry school is you can't force yourself to pursuit without an object moving. Like if I said, hey, can you just move your eyes in a natural arc? What you're really doing when you try it is you're doing little saccades. You're finding these small targets and you're actually just looking at them going, doot, 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 doot. But if you were to watch an object move, all of a sudden it'd be smooth. It'd be like natural arcs going through the air. So when this happens, it can affect things like your ability to walk. If you can't, observe a moving object naturally and your eyes aren't moving itself naturally to that object, it's going to be very overstimulating, very disorienting, and it's going to give you lots of problems. Likewise, if you can't saccade, your reading is going to be severely impaired because you can't move your eyes naturally to where you want them to go. And so we have lots of ways that we can help with this. One is a rotator. We want this object to be in motion because pursuits happen in motion. And as this little girl puts these little golf tees into these small holes on this moving disc, she's able to watch and pursue and find more precise movements as she rebuilds her eye-brain connection. The Bioness Bits is a fantastic tool for this. It has both saccade and pursuit programs built into it. This is one of the most powerful tools we have in inpatient rehab because we can target either saccades, pursuits, or both, and we can also incorporate this with other therapies. So I'll just wrap up with some of my affiliations and collaborations. So if you're looking for me, you'll sometimes find me in acute care, inpatient rehab, and then outpatient. I primarily work at SSM Rehab Hospital in Bridgeton. See patients there every Wednesday, but I also go to St. Mary's in Lake St. Louis. And then we just recently added Mercy Rehabilitation Hospital to our circuit. And then this is my clinic in Wildwood. If you want to come visit me and say hi. We do all full scope optometry, eye exams, contact lenses, but we also specialize in the neurovision rehab. And I thank you all for, again, letting me talk about this subject that I'm very passionate about. And hopefully I did okay on time.
We have maybe a minute for questions. Yeah.
Okay, so the KF credit,
Yeah.
you mentioned it's 5 to 10 minutes per day. Is that like total? I mean, you know what I mean?
Mhm.
Let's say like my OT friends, they do like the bits in the morning with the prisms, but maybe in PC, I'd like to have my patient do a visual screen test while walking.
Yeah.
Maybe later in the day. Is that not appropriate for the add?
That is a type of treatment I would call evidence informed, which is sometimes what we'll say, if you were to follow it to the letter, yes, you do it for a certain amount of time, you'd use a special apparatus with a special technique. But you can still get the effect, independent of following it to the exact letter. So I would say, even as little as 2 to 3 minutes, you can see some improvement. The important thing is that you have the prisms oriented in the correct orientation. So that's either left or right. You've got some kind of proprioceptive feedback that the patient's able to create some stimulus that way. And then it seems that the studies agree that a return to baseline is important. So sometimes we'll say either tap your chest, tap your nose, or have a central fixation target on whatever tool you're using. And that way you're not hovering. So in other words, you don't have a target here and then a target there. You'll have a target here and then a target over there. And then you'll touch your nose, target over there, touch your nose, target over there. So, yeah.
I have a question.
Yeah.
In the driving seminar, they talked about successfully using prism glasses for drivers. And I see the prism techniques you're talking about here.
Yeah.
How are those similar or different?
It's a great question. I could do a whole talk on prisms. But so far, we've talked about prisms for hemispatial neglect, high-powered joint diopter yield prisms. We've talked about prism for diplopia, which is usually one eye, sometimes it's two. We're going to reorient the images so the eyes can see them better. Let's talk about adaptation. If you have a field cut, is there some way that I can help you become aware of it? Is there an adaptation that we can do? And that's generally what he's talking about. Stephen Ice, the OT, he's fantastic. And so we'll sometimes fit a patient in what's called a Peli lens. And what that does is it moves images from the irregular visual field into the regular visual field, not temporarily or therapeutically, but literally permanently, so that the patient actually is demonstrated with a ghost image above and below in their superior and inferior hemifields. And it's almost like a side mirror in the car. So the way I describe it is, you don't look in your side mirror all the time, but if there's motion, if a car is coming right up on you, your brain is triggered to look, because you're using your peripheral vision that's very good at motion detection to attend to something that's happening, the stimuli that's over there. And what the Peli lenses do is they move those motion blurs into the usable visual field so that you attend the same way that a normal person would. Yeah, that would be a great slide to have on the presentation.
Are you able to stay after?
Yeah. Absolutely. Okay, yeah, thank you.
We can stay right here, salon suit. And we have a little gift of appreciation. Thank you
Oh, thank you.
so much for coming.
Thanks, appreciate that.